Hi, everyone. I'm Dr. Steve Levine. I'm a psychiatrist and I'm co-founder of Heading Health, which is a psychiatry and therapy practice that's based in Texas with offices in Austin and Dallas. And I am joined here tonight by Dr. Tyson Lippy. Tyson, please say hi to the nice people. Tell them who you are.
Hi, everyone. So I'm Dr. Tyson Lippy. I'm one of the psychiatrists in the Austin Clinic for Heading Health.
Thanks, everyone, for joining us this evening. The agenda tonight is that we're going to talk with you a bit about a newer treatment option for depression, and particularly difficult to treat depression, what's sometimes called treatment-resistant depression. And this usually refers to somebody who's had at least 2 attempts at treating their depression with an antidepressant and not been able to benefit. And like I said, Spravato, which is also called S-ketamine, is a newer option. So we're going to go through some facts about what Spravato is, some of the history of how it came to be, how it's a bit different than traditional antidepressant options, and hear a bit from Tyson, from Dr. Lippy, about his experience of treating patients with Spravato at Heading Health. And so first, let's start with some history, because Spravato, or again, it's also called S-ketamine, has an interesting history. And to talk about that, I think we first need to talk about anesthesia, which may sound weird, because I said that I'm a psychiatrist and we're a psychiatry practice, and now I'm talking about anesthesia. But bear with me for a minute. Hopefully this will make sense. When somebody is having surgery or some kind of painful procedure and needs to be given anesthesia so that they can be asleep or not move or not feel pain during that surgery, they're given anesthesia. And most medicines that are given for anesthesia do things like lower your drive to breathe or lower your blood pressure or your heart rate. And that's important in terms of being able to go through that surgery. But it can be a little bit dangerous medically. And so a long time ago, 60 years ago, a guy named Cal Stevens, who was working for a pharmaceutical company called Parke-Davis, was charged with coming up with a new type of medicine for anesthesia, and one that was medically safer and could be given to people even if they were in conditions outside of an operating room. And so he came up with this medicine called ketamine. And ketamine was tested through the early 1960s. He developed it in 1962, was tested during the 1960s. It was FDA approved as an anesthetic in 1970. And the first real use of it was on the battlefield during the Vietnam War, where it was known as the buddy drug, because it was considered so safe that your untrained buddy under uncontrolled conditions could administer this to you on the battlefield so that you could be evacuated and they could take care of you medically. It made its way into operating rooms stateside. Pretty quickly, it was relegated more to use in children, for short procedures in children. It's also used in animal medicine. And so it's developed a reputation. Some people know it as a cat tranquilizer or a horse tranquilizer. But it is a medicine that was first developed for people, and a really important one because of its unique safety profile. Well, flash forward a bunch of years to the 1990s, and researchers at Yale University and then at the National Institute of Mental Health started looking at ketamine for other reasons beyond just for anesthesia, because they had an idea that people with psychiatric conditions, when given low doses of ketamine, might respond differently. So in a study in the late 1990s that was then published in 2000 in a journal called Biological Psychiatry, they looked at giving people with treatment-resistant depression, a difficult to treat depression, just a single low dose of this medicine ketamine. And what they found, which was very surprising at the time, was that people got almost immediately better, significantly. Their moods improved overnight. Was a very unexpected finding. It's also very different than what we're used to seeing with medicines like Prozac and Lexapro and the antidepressants that we're used to hearing about every day and many of us take. And so it wasn't clear what this meant. We never know in early research whether this really represents something real or just an unexpected finding. And over the next decade, multiple other research studies were done that showed very similar findings, that even though people weren't taking ketamine every day like they would with an antidepressant, they could have a very rapid acting antidepressant benefit that was also pretty durable. It lasted a pretty good amount of time beyond when they had the ketamine. So back in 2010, I started treating patients with ketamine in an intravenous form. So an IV line is placed in somebody's arm, and the medicine is in a bag, and it flows through a tube and into the person's arm. And that is one way that this older version of ketamine can be given. However, in 2019, a new formulation of ketamine was developed. And this is where the story gets interesting. Because first of all, I'm going to tell you some $5 words that you can use to impress your friends, but I'm going to explain them too, I promise. Lots of medicines exist out there in forms called racemic mixtures. A racemic mixture is the mixture of what are called enantiomers. That's that $5 word. Enantiomer is ENANIOMETER, I think. No, it's not. It's ENANIONAM. I can't spell this right now. You try spelling a big word like that when you're on a live webinar. Please look up enantiomer. But excuse me, what an enantiomer is mirror image molecules. Excuse me. I also just got my voice back today after losing my voice for 3 days. So please bear with me. Apparently my memory of how to spell enantiomer went with my voice. Maybe that'll come back too. Okay, enantiomers are mirror image molecules. They're kind of like hands. If you put your hands on top of each other, right, they're mirror images of each other, but if you put them on top of each other, they don't line up. So they're mirror images of each other, and they spin in different directions in space. So why am I bothering to mention this? Why is this important? Because a company took ketamine and they split it into its two enantiomers, its two components. Its S and its R components. And they developed the S one, the S enantiomer called S-ketamine, as this new medicine called Spravato. And they were able to put it into a nasal spray, which many people find to be easier to take than having an intravenous infusion or an intramuscular injection. But most importantly, because they developed this not for anesthesia, but specifically for difficult to treat depression, it was approved by the FDA for depression, and it's reimbursed by insurance companies for depression. And the big advantage here is that unlike the older version of ketamine, which is called an off-label treatment, it's not FDA approved for use in depression, and therefore not directly reimbursed by insurance payers. And if you seek treatment with ketamine, oftentimes it can be fairly expensive when the money that you're paying out of pocket. With Spravato being covered directly by insurance payers, it's often a copay, and so much more affordable, and therefore it makes it much more accessible to more people, regardless of ability to be able to afford treatment. And that's something that's really, really, really important to us at Heading Health. We believe that everybody deserves access to high quality, affordable mental health care. So this is a treatment that we offer at Heading. And to tell you a little bit about how it works and why it's a bit different than usual antidepressants, if we think about Prozac or Zoloft or Lexapro, any of these usual antidepressants, the way that they're usually explained is a quote unquote chemical imbalance. Now, that's not really true. It's not a theory that's actually backed by science, but the basic idea that, excuse me, is that you have these neurotransmitters in your brain. Neurotransmitters are chemical messengers. They carry messages to different parts of your brain. And the most famous ones are things like serotonin and norepinephrine and dopamine. Those antidepressants mostly work on serotonin. Some of them work on norepinephrine and dopamine as well, but they essentially try to increase the availability of those neurotransmitters in certain areas of your brain, and that's thought to be related to improvements in mood. Many people do benefit from those medicines. They typically take several weeks or potentially months to work, but many people benefit tremendously from those medicines. But they do take a long time, and a lot of people don't get better with them. And that means that we need new options. We need to have more tools in our toolbox. And sure, it would be nice if they also worked a bit more quickly, because when somebody is severely depressed, especially if they've been waiting a long time to find something that can help them, every minute counts, right? And so we should have a sense of urgency in how we approach trying to take care of somebody with depression. The way that we think that Spravato works is a bit different. Instead of focusing on serotonin and norepinephrine and dopamine, Spravato works on a different chemical messenger called glutamate, the glutamate system. And more importantly, it has effects on the ways that the brain communicates across important regions through networks of the brain. We think that when people have depression, or when even they've had just stress, period, longstanding stress, you develop some difficulties in the ways that certain areas of your brain communicate with each other and the connections that are responsible for that communication. And it looks like Spravato, through its action on that chemical glutamate, has the ability to pretty rapidly repair those connections and lead to clearer thinking, improvement of mood, and potentially help to facilitate the work that's done in talk therapy. And excitingly, this is often a treatment that can work more quickly for many people than your traditional antidepressants. People can notice some benefits sometimes after a first treatment. Sometimes it can take a handful of treatments. Sometimes it could take a month. But on average, response tends to be more quick for those who benefit from it than with traditional antidepressants. And it's not taken every day. Most antidepressants you take every day, at least once a day. They're taken at home. Sometimes it's multiple times a day. And because you take them every day, people tend to have at least some side effects on a daily basis. Spravato is given on an intermittent basis. Excuse me. I'm just glad I have my voice, even if I'm coughing a bit. Excuse me. Spravato is given intermittently. When you first start it, it's given 2 times per week, and that's for the first month. And then it's tapered off after that. And one of the advantages there is that people don't have to take medicine every single day. And on the days that you're not taking it, you can avoid those typical antidepressant side effects. And the side effects that people do feel, which are on the day of administration usually, tend to be pretty mild and well tolerated, and we can talk some more about those. But I've been yammering on here for quite a while now. I'm going to give my own throat a break, maybe do a little bit of coughing, and invite Dr. Lippy into this conversation and ask you, Tyson, can you please talk a little bit about your experience with treating patients with Spravato at Heading Health, and anything about it that comes to your mind? And then we'll also be taking some questions from our live audience.
Yeah, so thanks for that introduction, Steve. Sorry, you're still getting over that. Yeah, so I have experienced, like all psychiatrists, doing a mix of therapy as well as primarily oral medication management. And I've also done some other forms of interventional treatment as well. And so I've seen how effective that some of the interventional treatments have been and how quickly that they work. And prior to working at Heading Health, so I was working somewhere else in the Austin area and saw the need for treatments like this, that unfortunately oral medications and psychotherapy alone, while effective for a lot of people, did leave a large number of folks still symptomatic. And so when I came on, I was very excited to get to use treatments like Spravato, knowing the data that, one, how rapidly it worked, but also how well it worked. And so it's been quite an experience treating patients with it. I can't tell you how many times I have patients who have come in, and the number of medications they tried kind of looks almost like a grocery list. It's very long. They've tried, not just different medications, but different classes, different doses, very long periods of time. They've also done psychotherapy and a lot of times other treatments as well. Then giving them Spravato, the majority of them tend to have a response, and it's been really good to see that. One person, for example, told me she had been on medications for almost 50 years. Spravato was the first thing that had worked for her, worked really well. It's continued to work for her. So hearing a lot of stories, patient stories specifically, and seeing that. And as a provider, it's also good to have something new as well. We haven't had a lot of new treatments in psychiatry in recent decades. It's been pretty limited. So to have another tool in our toolkit not only brings patients hope, it brings me hope too, that our field can evolve and meet the need that's growing and growing, especially with the pandemic that's happened and has brought a lot of things to light and exacerbated things. We're going to need more tools in our toolkit moving forward. So yeah, it's been wonderful to see. Like Steve said, there are side effects, there are risks with any medication, right? But they tend to be pretty mild. And most of the time, patients really enjoy the treatment. They describe it as pretty positive experience, sometimes neutral, but it's been really good. And it to the effect that Dr. Levine also said, a lot of folks have also done therapy before as well and had limited response, or they often say, therapy is just really not for me, or I didn't get much out of it. Seeing them go through Spravato and then encouraging them, sometimes badgering them because that's who I am as a psychiatrist, but getting them back involved in therapy, they say, I can get a lot more out of it, or it's been so much more fruitful or meaningful. So it really drives home that point you made earlier, Dr. Levine, of it facilitates people getting more out of therapy and getting some efficacy, not just with the medication, but also with the non-medication modalities too, which is good to see.
Terrific. And, within that, you mentioned you sometimes see patients who've been on a laundry list of medicines. And I've certainly had that experience too. And I think, one message that's really important for people to hear is that, I've talked to many people who've been on 17 different medicines, 20 different medicines. And the conclusion they draw, the message they're left with often is, I've tried everything. I've tried, dozens of medicines and nothing has helped me. And so most likely nothing will help me, right? Maybe I'm just somebody who can't be helped. Maybe I can't be not depressed. Maybe I'm hopeless or a lost cause. And one thing I always try to reinforce to them, because it's true, and I think it's a hopeful message, is that, yeah, maybe you've tried 17 different names of medicines. However, most of those medicines are pretty similar to each other because, like you said, we haven't had very much new in many, many decades. And even though new medicines have come out, they've really just been small tweaks on the medicines that came before them. So even when the SSRIs came out in the late 1980s, when Prozac came out in 1987, and all the SSRIs that followed, and that was supposed to be a revolution, they really weren't that different in terms of the way that they work from the older classes of medicines that came before them, tricyclic antidepressants and the MAOIs, older medicines that are still sometimes prescribed. But they all work pretty similarly. And so if somebody has tried 2, 3, 4, 5 different examples of the SSRIs or SNRIs or tricyclics or MAOIs even, and they haven't benefited from them, chances are they might not benefit from attempt number 5, 6, or 7 with the same kind of medicine because they're pretty much the same thing. And so I say to these folks that, yeah, you've tried 20 different medicines, but really you've practically only tried 2 or 3. And so, your depression may not be as difficult to treat as it seems. And it may not be that you have so much a quote unquote treatment resistant depression as an SSRI resistant depression. And some people are very lucky and they get a great benefit from an SSRI the first time they try one, and that's terrific. At least a third of people won't, and about 50% after they try the first one. And so having a new medicine that works in a different way, to me, is really, really important. It's also a hopeful message that we actually have something new to offer. And it also happens to be the first of a number of new options that are coming. We are in the midst of some exciting frontiers within psychiatry where we have a number of new tools coming. And so I think it's a time when people really should feel very hopeful, even if they've been frustrated to this point, that there may be new options that can help them.
And to your effect as well of saying there's some urgency, I agree with that. You present some of the numbers with the oral antidepressants like SSRIs, SNRIs, MAOIs, TCAs. But we know, and there's a lot of research, right, to show that with depression, it's not just depression, right? You have increased risk for stroke, increased risk for heart disease. Of course, it impacts your functional life and your work and your personal life. So there's a lot of costs to it too. And so while a lot of people come in on a laundry list of medications, you don't have to be on a laundry list of medications. Spravato was originally designed for 2 failed antidepressants. It is an option, generally is a safe option. It's a good option. And it's something that it's probably better to address your symptoms sooner rather than later, and waiting until you hit that 15th, 17th, 20th medication. It is costing your body something, and it's costing those around you something as well. So like you said earlier, it's a little bit of an urgent situation. So why not try something new that can address that more urgently?
Agreed. And one other thing that I think I hinted at earlier, but should maybe be clearer about, is how Spravato was taken. Because we talked about it being different than medicines that are taken orally at home. Spravato is given in the office. So you take it yourself, you administer this nasal spray yourself, but you do it in the office with a team of people around you. And to me, that's a big advantage of Spravato and something that's really nice about it. What we've seen in psychiatry and psychology, especially over the past 3 or 4 decades, is that we've really split off medication treatments from talking to people. And that's very sad to me. In some ways, it makes prescribing medicines seem like people are just a bag of chemicals, and you sprinkle in some new chemical and they should just feel better. But people are more complex than that. People have complex lives. They have things that they want to talk about. They need support. They need human connection, especially when you're depressed and people are often feeling so isolated. And the fact that Spravato is given in an office setting, and typically not just with one person there, but a team of people who care a lot about you and want to see you get better, and have the opportunity to talk with you while you're there and really spend a lot of time with you, that's a big deal to me. And I think it's really a unique aspect, and something that probably lends itself to some better outcomes, because it's not just taking medicine at home. There is this experience that you go through of the feeling of the medicine itself, but then being in this nice, warm, supportive environment with people caring for you who are working together to try to help you feel better as quickly as you can.
And we've got several questions, so don't worry, guys. We're not ignoring those. I'm keeping track of them. But to that effect, as a psychiatrist, you're right. So there's a big separation even in residency training now. Like, are you going to a biologic residency or are you going to a therapy residency? They're tending to split ways, as you said, a little bit more, just really focusing on the medication piece, or the therapy. You're doing a good job of bringing it together. But as someone who's, trained in both, it's wonderful to have someone come in, have Spravato do a lot of the work, people get to feeling better. but to see them more frequently as opposed to once a month for a 20, 30-minute med check. How do you boil down everything that's happened in the past 4 weeks in a few minutes, as well as discuss everything medically as well? Seeing people twice a week, once a week for Spravato following that protocol, it leaves a lot of time to talk about other things and focus on other things. How is your sleep doing? What are some things we can do with sleep hygiene as well? And also, as people do respond to Spravato and get better, you can focus a little bit less on the medication, the treatment protocol, and focus more on, okay, let's talk about lifestyle, let's talk about nutrition, let's talk about coping skills. What are some of your cognitive distortions? So I think one, it's great for patients. It's also good for providers as well, being able to utilize some of those skills that are a lot of times underutilized with psychiatrists.
Yeah, excellent points. You mentioned the questions that are rolling in. Yeah,
Yes.
I see a few of them. So why don't we start answering some of those? And I see the first one is, can this be used for bipolar? And also if they have a substance abuse history. So I'll take that one. So it depends if we're talking about Spravato or ketamine. Like I mentioned earlier, ketamine is the medicine that really led to the development of Spravato, but it is an off-label treatment. It's not directly reimbursed by insurance. And so because it's being used in an off-label way, there's a little more latitude to prescribe that for a range of indications that have some research to support their use. And there have been some studies of ketamine for bipolar depression, and the results have been mixed, but there are people with the depressed phase of bipolar disorder, not mania, but the depressed phase, who are able to benefit from ketamine. Spravato, on the other hand, is directly FDA approved for major depressive disorder, and one that has not benefited from at least 2 attempts at treatment. And it's directly covered by insurance, but it would be covered just for that indication. So just for that difficult to treat depression, or if somebody has depression and they're having some suicidal thinking. And so in that way, Spravato typically wouldn't be prescribed for a diagnosis other than major depressive disorder. As far as substance abuse disorders or people who have had difficulty with substance use disorders, well, it depends. So with Spravato itself, or really I should maybe speak about ketamine, there is some potential for abuse. Some people do abuse ketamine. Typically not when people come for depression treatment. We don't see people coming in to treat their depression and developing some difficulties with taking Spravato. But sometimes people do use the medicine ketamine recreationally. And so it does mean that we want to be careful about people who may have some sensitivities to have other substance use disorders. So that said, just because somebody has a history of a substance use disorder doesn't mean that they wouldn't be appropriate to have Spravato. If somebody does have an active substance use disorder, then we would recommend first that be addressed and that they have some period of time where they're in at least an early part of recovery before having this treatment. And if for no other reason, then let's say it's alcohol. Alcohol is a depressant, and so if you're actively drinking while trying a depression treatment, whether it's Spravato or any treatment, it's unlikely to benefit you. It would likely undermine your response, and so also we would make it difficult to even make the diagnosis in the face of actively abusing alcohol or other drugs. And so, making that long story shorter, a history of a substance use disorder wouldn't exclude somebody from having treatment with Spravato, but an active substance use disorder would be something that we'd want to address first.
To that effect too, that's why Spravato is very regulated by the FDA. You have to follow pretty strict guidelines for treating patients as well, and that's part of the concern. And so that's why we also bring people in office for intramuscular ketamine as well, is to make sure we monitor them for safety. So that's part of it. Another question we had is, why do you offer intramuscular ketamine if you have Spravato? Don't they do essentially the same thing? So I'll take that one. Dr. Levine talked a little bit about it. A lot of the reason why you would offer intramuscular ketamine is because there is a little bit more leeway, since it's not strictly governed by insurance approval with prior authorizations, for maybe some of the other conditions or indications where there's research, but it's not, Spravato is not necessarily FDA approved for. And so it gives us some other indications that we might be able to help people with. And as far as do they do essentially the same thing, the mechanisms of action or how they work incredibly similar. And that goes back to when Dr. Levine was saying that Spravato is S-ketamine, or essentially, part of the racemic mixture of ketamine, which is R-ketamine as well as S-ketamine. So they are very closely related and have very similar ways of working.
And there was another question about what diagnosis people need to have. And so I think we probably mostly covered the answer to that question, answering a previous question. But yes, for Spravato, somebody must have a major depressive disorder and have tried at least 2 other treatments within this episode of their depression. And it's given along with another antidepressant they're already taking. Unfortunately, at this point, it's not approved for bipolar depression. Maybe at some point down the road, the indications that are covered, that are researched and covered, will be expanded. But at this point, it's limited there. And so maybe I'll just go right into the last question that I see here right now, which is that, is there a future for psychedelic treatments beyond ketamine? Great question. So I mentioned before, there's lots of reason for excitement and hope right now, because there are potentially a number of new treatments that will be available for patients in the next couple of years after decades of really not having anything truly new. We now not only have Spravato, but there are some very promising psychedelic therapies being developed. In particular, MAPS is developing MDMA-assisted therapy for post-traumatic stress disorder. A company called Compass Pathways, and full disclosure, I work for Compass Pathways, is developing psilocybin therapy for treatment-resistant depression, so the same indication as for Spravato. These are still in clinical trials. These are still being tested for FDA approval, so they're not yet available, but there's hope that within the next couple of years, the next year or two, that MDMA for PTSD may be available. And within the year or two after that, that psilocybin therapy for depression may be available, treatment-resistant depression. And should they be approved, these are both treatments that we would intend to offer at Heading. Our aim is to offer as many evidence-based treatments that can benefit our patients as possible. And so these are things that we are excited about.
So, see another question. Can you say more about its use with OCD? Like we've said a couple of times, or a few times, right now Spravato is not FDA approved or insurance covered for OCD, so hopefully there will be further indications further down the road with it. But there has been some evidence to show ketamine's use with OCD, some small studies to do with that. So definitely hopefully more stuff coming down the pipeline as well.
And what we typically see in psychiatry is that a lot of our medicines, even some of the older ones, can potentially treat a number of different conditions. Mm-hmm. But the way the FDA approval process works is that the research needs to be done for a very specific diagnosis, and then it's approved just for that diagnosis. And to be approved for another diagnosis, they need to go and conduct research on that one. And conducting these trials takes a long time. It's very expensive. And so typically a manufacturer will pick, 1, 2, maybe 3 indications that they seek approval for. And outside of that, medicines wind up being used off-label. If there's otherwise research that shows that the medicine could be safe or effective for that diagnosis, then doctors are permitted to prescribe off-label. When medicines are older and inexpensive, insurance companies tend not to be too picky about that. And they'll pay for the medication even if it's off-label. With some of the newer treatments, which can be a bit more expensive on the payer side, not to a patient, because usually that's just a copay, but that's more expensive for the insurance company, then they require what's called prior authorization, which is their approval to prescribe a treatment before you're able to prescribe it. And in that case, they typically want to make sure that somebody has the right diagnosis in order to pay for it. And so I think what we'll see over time is that the manufacturer of Spravato may conduct further research and seek further approvals for more diagnoses. And that's something I'm hopeful about. And so whether it's Spravato or some of the other new treatments that will be coming down the pike in the near future, they should cover some diagnoses beyond just depression.
Don't see any more questions currently, but figured I could answer some of the more common questions I get from patients when they come into the office and they're asking about Spravato. So a lot of people will wonder, what is the treatment like from the time you walk in the door to the time you leave, kind of what is that like? And at Heading Health, so you will check in like you normally would. You would be then brought back into a private room, and you could have a spouse, a friend, a family member with you as well during your treatment in the private room. You'll have your vital signs checked. One of the providers would sit down and talk with you. So myself, as an example, get an idea of what's been going on, how the treatments have been going, get updates, maybe make adjustments to the treatment plan that we had come up with. And then after all that is cleared, you would receive your treatment. Because of FDA requirements, you have to be in the office for 2 hours for close monitoring. So some of that is coming in, checking vital signs, seeing how folks are reacting to the medication, as well as there's always just some talking and kind of getting updates, as well as how things have been going. So once everything is gone, you finish your treatment and that 2-hour limit, folks go home. So they do have to have someone drive them home after the treatment. And they're free to continue about the rest of their day. So most people do pretty well the rest of the day of treatment. Sometimes people feel a little tired or groggy, but once you get a good night's rest, then the next morning you can go back to sort of normal day-to-day activities, status quo. So all in all, it's fairly routine, but there's just that little bit of a waiting period, but it leads to a lot of time to be able to kind of catch up, chit chat, and other things between your treatment team as well as whoever's joined you in the room too. I think we did have another question. Are there any risks for patients that maintain treatment over a long period of time, say several years? It's a good question. So the makers of Spravato actually just published some research. It was some 4-year long-term data showing that most people who maintain Spravato or continue Spravato maintain their benefits, and that it overall is safe. The rate of dropout due to adverse effects is actually pretty low. So they originally had some, correct me if I'm wrong, Dr. Levine, they had some data for 1 year, and I think it was just more recently that they published, their 4-year long-term data.
Yeah, exactly right. And, I think it's important to acknowledge that, we can never say that something is without risk, right? Either in the near term or in the long term. We should never take the prescription of any medication lightly. Anything has some potential to do harm, and it's important that we have open conversations about what those potential risks could be. Fortunately, it seems, as you're saying, Dr. Lippi, that Spravato now has some data to show that it can be safe when administered over a period of years. We can also look to ketamine, which, as you said, is a very similar drug. And ketamine has been used for over 60 years now. And even in the context of treating people with depression, that has existed at this point for about a dozen years or so. And many people have had maintenance treatment over long periods of time. And academic centers like Yale have published some of their long-term data of people who've received treatment over long periods of time. Fortunately, we have not seen evidence that there are harms with extended use on an intermittent basis. With Spravato specifically, there is something called a REMS, which is a registry. And this was put in place when it was FDA approved back in 2019. It's one way of tracking how people do with this medicine over time. And so that's another safety mechanism so that if there are any risks that weren't anticipated, they will hopefully be caught and we'll know about that. But again, so far, it seems like this is something that could be safely taken over time. Always are potential risks. We also need to weigh those, of course, against what are the risks of untreated depression. And of course, some of those include suicide, the impacts on people's social functioning, their ability to work. And as you were mentioning earlier, Tyson, we also know that when people have untreated depression, they can have some very serious medical comorbidities, medical conditions as well that develop over time. And so I think all of these things need to be weighed. And again, it's a reason why we really should have a sense of urgency when we approach depression so that people can have the best long-term outcomes in health.
Don't see any more questions this time, but keep them coming for sure.
Come on, give us the hard ones. Stump us. I think I'll give you an example of a good question. Here's a good question. How is it that Dr. Lippy can both be so smart and so good looking? That doesn't seem fair, right? So questions like that are certainly welcome. But we can also just keep it about Spravato also. Look, somebody just asked that very question. Here's another question, actually. So you were saying that when you're treating patients at Heading Health with Spravato, you've seen that the majority of people do have some benefit, but I'm sure some people don't benefit from Spravato. So what then?
Yeah, it's a good question. And so it's always a case-by-case basis, right? That's kind of the definition of good medicine, right? There's no one size fits all. And so sometimes what you can do if maybe someone is not responding quite as well as you would hope, you may extend their induction phase so the twice a week a little bit longer. There's also been some evidence to show that some of the other oral medications that we use for depression or augmentation